Is it true? Wait. Let me just check with Ravi. How is it? No issues? No, you don't need to see me. You have to see sir and the slides. Is it there? Now is it okay? Can you see the slide? Okay, we want. Okay. How is it now? Better? Little more? Tell us when you're happy. You're fine? Okay. So tell us when to start and sir will start. You saw the number. Well, 12. Yeah, 12. Yeah, 12 sharp will start. Okay. You're happy? Okay. Why should you see me? I'm not there at all. Okay. No?
But can you see me?
See. Now you can see only sir, right? Yeah. Okay, Ravi. Yeah, 12 sharp will start. Okay, bye.
You can hear me through this?
Yes.
You can hear.
Yes. That's what we want everything. So 12 sharp will start. Another 2 minutes. 1 more. 2 minutes.
You can put it on.
Hmm?
Can't you put it on?
It is on.
On.
It's on. You start talking.
But I can't see my face.
You can't. That's the difference between YouTube and this. That's why it's getting so confused.
Okay. So I won't see my face in this.
No.
Okay.
Seconds to go. 10 minutes.
Hello Ravi, can you hear me properly? Can't answer. She started. Ravi?
Can you hear, sir? No problem? Start.
Okay. Good afternoon everybody. I'm going to present bladder augmentation in children. It's one of my favorite topics, so I could go on and on, but like to restrict myself to the given 40 minutes. So I do not know whether this is the best way to spend a Sunday afternoon, but there we go. Now before I start, I would like to thank my colleagues in PSG, Dr. Pave and Dr. Senita, without whose help this presentation and especially its electronic transmission would not have been possible. In fact, we are projecting it from Pave's home. I also would like to thank my friends and colleagues in CMC Vellore, Department of Pediatric Surgery, because about 3/4 of the case material in this talk belongs to that department and institution. Now, why am I going on and on with this slide is that I want you to copy down these two numbers at the bottom, because if you have questions, you can send it by WhatsApp to these two numbers. Now, what is bladder augmentation? A picture speaks more than 1,000 words, and this shows that a bladder which is tiny with very poor storage ability, irregular, can be made into enormous storage space by putting a bowel patch. And basically, this is what augmentation is. And this additional storage space works wonders for many of the problems associated with lower urinary tract disease in children. So that is what augmentation is. Now, before we understand augmentation, we must understand a bit of bladder physiology. Bladder is very simple organ, not like the heart with so many chambers and valves and all that. It's only one chamber. It's a very humble organ, but it's got two seemingly easy functions. One is low pressure storage of adequate capacity and periodic emptying of the storage to completion. Now, when things go wrong, bladder augmentation is a unphysiological operation, I must say that, which has got a tremendous positive impact on the low pressure storage, but a negative impact on the emptying to completion. And both factors must be borne in mind before we embark on bladder augmentation. Now, normally the bladder stores adequate volume, that at least 3 hours urine output at low pressure of less than 10 usually, but let us say less than 20 centimeters of water. And if the pressure rises beyond say 25, it gets increasingly dangerous for the kidneys. So we are now concentrating on the storing function of the bladder. Now, abnormal bladder storage is of two types. It can either not store at all, as is seen in gross sphincter incompetence, or it can sometimes store large quantities, but at high pressure. And it is the storage at high pressure which causes the upper tract damage. Well, if they can't store at all, their upper tracts are normal, but they will want to be dry, and we do some sort of outlet surgery, be it neurogenic bladder, be it exstrophy. And once we do the outlet surgery, they store often at high pressure and upper tract damage ensues. Now, which bladders seen in children are unable to fulfill the criteria of good storage and good emptying? One is congenital outflow obstruction. Our favorite condition is posturethral valves. Neurogenic bladder, including non-neurogenic neurogenic bladder, and exstrophy bladder. These are the big three. There are a host of other conditions, including anorectal malformation, particularly cloaca and its sister, the UG sinus, then bilateral ectopic ureters and its sister, bladderogenesis, and of course trauma and tumors. Now let us concentrate a bit on the big three, the common diseases of micturition in childhood: posturethral valve, neurogenic bladder, exstrophy bladder. Now we always think of them as voiding disorders. Like for example, posturethral valve is unable to void because it's got a valvular obstruction. Neurogenic bladder has got a sphincter spasm of the external sphincter, which makes a dilated posterior urethra. And exstrophy bladder, we construct a tight sphincter so that they enable to give some resistance and storage. But these outflow obstructions common to posturethral valve, neurogenic bladder and reconstructed exstrophy ultimately gives rise to a angry storing bladder at high pressure, because the bladder revolts against such obstructions, and it is the storage function, which altered storage function, which causes the kidney damage, especially because at night, because most of the day we are storing urine rather than voiding urine, but especially at night we are storing, unless you happen to be a bedwetter. You do a lot of damage when the angry bladder is trying to store urine at night. These are some of the examples of same conditions: posturethral valve, neurogenic bladder and exstrophy bladder, which manifest as storage disorders even after the primary condition has been treated. See, the posturethral valve, the valve is gone, the urethra is no longer dilated, but the bladder remains high pressure with massive reflux. Neurogenic bladder having big reflux, and even the other kidneys hydronephrotic, though not refluxing. There's an exstrophy bladder with sphincter constructed, but you see the bladder has become irregular with bilateral massive reflux, and it's well seen in an urodynamic study which shows as with the filling proceeds, the pressure rises to very high levels. So this is how a voiding problem can become a storage problem, which is more relevant for the deterioration of the kidneys. Now, how did the clinical presentation happen in children needing bladder augmentation? As I said, bladder has to store and to void. Now, just remember two questions and you will know everything how the clinical presentation is. The mother says in early childhood, the doctor, nobody wants to sit with my child in school because he's smelly, he's dry, he doesn't even attend school most of the days because he's sick, he's got urinary infection or epidermolysis, so he is an outcast in school and probably we don't even send him to school. But if not properly treated, the next question comes in adolescence or early childhood, the doctor, we can't afford a renal transplant because by now the child has gone into renal failure. So these are two sad, very sad questions because a bad childhood going on to a bad adolescence. And it is this group of patients where augmentation, timely done, can make a tremendous difference. Now, that is the clinical presentation. When we investigate the need for augment, the usual investigations are done. Urodynamic changes, as I showed you, high pressure urodynamic, but often urodynamic studies are not done very early because we wait for other changes to happen before we think of urodynamics. Radiological changes on MCU, a trabeculated bladder with or without reflux. Cystoscopic findings, very important. You see the bladder trabeculation. Now, this child happens to be a case of post-urethral valves, but so trabeculation is expected. But if you see the same trabeculation in a case of what you think to be primary reflux, big massive reflux, you want to do a reimplantation, and you find the bladder is trabeculated on scopy or when you open, please consider augmentation because this may be a case of non-neurogenic neurogenic bladder, and often the urodynamic studies may not help you because of the massive reflux. So therefore I put a lot of importance on the appearance of the bladder, especially in the case of massive reflux of unknown cause. Then again, VUR, hydroureteronephrosis with or without VUR, and of course a child with increasing renal failure needs to be investigated whether bladder is the cause of the renal failure. Now, decision to augment is actually more difficult than to do the augmentation. Augmentation anybody can learn. It is not a very technically hi-fi operation, but the decision to augment is the very important issue. Now, let us start with again the basic conditions, PUV or be it neurogenic bladder, be it exstrophy or maybe others. Proceed to the primary management. Augmentation is never a primary management. The primary management, as the case may be, could be valve fulguration, intermittent catheterization, anticholinergics, alpha blockers, exstrophy primary repair, etc. etc. So after this is done, we have two situations. Either the bladder recovers and continues to be well, or the bladder worsens. And if the bladder worsens, if untreated, it will cause continued incontinence, continued episodes of UTI, and ultimately renal failure. And you must recognize this syndrome that a sick bladder not recovering continue to have problems, and if you let it go, then you lose your chance. And a bladder augmentation at that stage will halt this cycle of deterioration. Now, that is a general principle, but I just want to illustrate the little more closer detail at each of these conditions. So the need for augmentation in post-urethral valve disease. Of course, as I said, we have started with ablation of the valves. And after ablation of the valves, there are two things. Either the whole system gradually recovers, and I put a thick arrow there to show that that's what usually happens. Gradually, if you give it time, the child, most children will recover, the bladder will recover, the kidneys will recover, symptoms will abate, creatinine will settle. But there is a few who continue to have problems. And the problem is because the bladder remains hypocompliant for a longer duration than is expected, especially compounded with reflux. It causes UTI, and with each episode of UTI, there is sometimes rise of creatinine, which settles down after the UTI settles, which means there is a reversibility in that. But each episode of UTI will spoil some more kidneys, increasing hydroureteronephrosis and incontinence of urine in between normal void. They are able to void normally because the valve has been ablated effectively, but in between the dribble because of bladder malfunction. Now, often our tendency is to, okay, let us fulgurate the valve again. That is not the way to go. Of course, it's incomplete, you have to do it, but again and again, fulguration is not the answer. That the problem is not at the valve level, problem is at the bladder level. And what you can do in early childhood especially is pop-off diversions. I believe a lot in pop-off diversion. It may be a vesicostomy. If you have a large refluxing ureter, it could be a low loop ureterostomy, which can decompress the whole system. And give it time to recover. And if it recovers well, you reassess and you may be able to undivert the patient. But if you reassess and the bladder function has not recovered, you have to do undiversion with augmentation. So this is a general idea. Next. Sorry. Some examples will illustrate the problem. This is a child showing trabeculated bladder, valve has been adequately fulgurated, and he's got bilateral reflux, massive on the right side, less on the left side, and he has been fulgurated elsewhere, but he comes to us with episodes of UTI and intermittent rise of serum creatinine, just the situation which I described. Ultrasound shows a very thick bladder. So what is his problem? He doesn't need a urodynamic study actually. The problem is because of a hypocompliant bladder, bilateral hydroureteronephrosis. So what should we do? Should we just let it go? Tell him that things will become better? No. Then he will lose more and more nephrons. You have to do something. But not augmentation. It's not the time for augmentation. I want to start the talk with when not to do augmentation. So the management at this stage, the child is still an infant, should be a pop-off diversion. In this case, you could do a vesicostomy, but in this case, we've done a low refluxing loop ureterostomy on the massively refluxing side. Remember, the valve is already fulgurated. So that loop ureterostomy, because massive reflux, will decompress the whole system. So both channels are open. Urethra is also open and the ureter is also open. Now, as expected to our sort of pleasant, not surprise, pleasant expectation, that the kidneys have become much less hydronephrotic and the bladder has become so beautiful and the reflux has stopped spontaneously. We have not reimplanted. And so he comes for undiversion and we were able to divert him. You could have just closed the ureterostomy. Instead, I did a trans ureterostomy and left the ureteric stump for night drainage catheterization. So this child did not need an augmentation because with our pop-off diversion, he recovered without further loss of nephrons. So this is where augmentation was not required. But a very similar child, valve has been fulgurated, and this is a pre-valve fulguration picture showing massive reflux and a trabeculated bladder. And he came to us 2 months after fulguration with bad UTI. Serum creatinine was 2.1 milligram %. So what should you do? We know the answer. We did a loop ureterostomy on the massively refluxing side, and the child recovered very well. Serum creatinine fell from 2.1 to 0.6, and 3 years we didn't do anything more. We came back for undiversion after 3 years. But at re-evaluation, we found the hydronephrosis has settled nicely, but the bladder remains a small, tight compartment, and the valve has been fulgurated adequately. Of course, one side is ureterostomy, the other side reflux has persisted. In fact, that is the better side. Reflux has persisted, and a urodynamic study shows the pressure going up to 100 centimeters of water. So therefore, in this child, the child is well because the kidneys are kept well, but the bladder has not recovered. So we don't know why. Persistent hypocompliance after 1 year, we put him on oxybutynin, but there's still the same situation. Now this child, if we just close the ureterostomy, we'll back to square one. So we've undiverted with an augmentation. So reconstruction done for this child was a TUU and an augmentation with a Mitrofanoff. And see the follow-up, the kidneys are remaining well, and this is the augmented bladder, and serum creatinine remains at 0.6, and he has come for follow-up recently also. This is many years ago. His still creatinine is 0.6, 0.7 like that. So therefore, we have succeeded in this child to avoid a disaster by timely sensing the need for augmentation and doing it. So what are the lessons learned from cases 1 and 2? We can't predict which bladder will recover and which will need augmentation. A pop-up diversion gives us time to watch and think without losing more nephrons. Now overall, what is the overall need for augmentation in PUV? Is not much, but it helps the few select patients where the bladder remains hypocompliant. The overall augmentation rate in 334 patients was 27, that is 8%. These are little old figures, and old figures are better than, more reliable than new figures, because now, since rightly or wrongly people think of me as an augmentation person, people keep sending patients for augmentation. So it's a biased study. But these are all figures from Vellore, all run-of-the-mill cases coming, and we needed 8% to be augmented. Recently, we reviewed 54 valves which have been treated in the neonatal period for a long time, and only one of them ultimately needed augmentation. So there's a very select position for augmentation in post-urethral valve. Now going on to in neurogenic bladder, as I told you, has two types: a storing bladder or a non-storing bladder. Now storing bladder causes more damage to the kidneys, but non-storing bladder, the problem is getting continence. If you do CIC, you will get only 10 cc of urine, doesn't help anybody. So the storing bladder can be storing at reasonable pressure where the hydronephrosis will be not there or very mild, and no VUR, very mild VUR. This can be very well treated with CIC and drugs. But the portion with major hydronephrosis, and particularly with dilating VUR, have high pressure bladders, and they benefit from bladder augmentation, which should not be delayed, because more we delay, more nephrons we lose. Non-storing bladder, there is no hydronephrosis, no VUR, and there is no hurry to treat them with surgery in childhood unless they want to be dry. And when they want to be dry, the just an augmentation will not help. We need to do a bladder neck procedure, especially a bladder neck sling in neurogenic bladder. That's what I do. But if you do it alone, again you're going to land up with a high pressure system, and therefore I always do an augmentation with a Mitrofanoff for CIC in these patients. So overall, so this is a general plan for neurogenic bladder. Definite need for early augmentation is major hydronephrosis, especially with reflux. I call this a pressure cooker bladder. Pressure bladder is just like a pressure cooker. Now, bladder augmentation was needed out of 300 patients treated, run-of-the-mill patients. 78 needed augmentation. That gives a rate of 26%. But this percentage will increase as more and more children become older and they want continence, particularly the non-storing bladders. Now, I just want to highlight the danger of reflux in neurogenic bladder. So, this is a child with obvious neurogenic bladder, and it shows what we would call maybe a sort of mildish reflux on the right side. But it is not really mild. You see the kidney is already scarred because it is a high pressure reflux. Even the other kidney shows some scarring, though it is not refluxing. Another child with bilateral reflux is the case of neurogenic bladder. You can see the early Christmas tree happening, and you see both kidneys are scarred. Another child with unilateral reflux, you see that particular kidney has been almost become non-functioning. So this is just to emphasize that reflux in neurogenic bladder is dangerous. So high pressure neurogenic reflux, we have a very special responsibility for these patients, because remember that all these kidneys were normal at birth. It's not like a PUV disease. All these kidneys are normal at birth, and augmentation with reimplantation, we'll talk about that later, is the answer to prevent further deterioration, although young children can be temporized with a vesicostomy. Now, the other group of children with normal upper tracts, inability to store, there are the neurogenic bladders, a few are like that, minority I must say, and so the small bladder. This is a big child, one of Pave's patients with a small bladder, and if CIC yields only 30 cc of urine, so this child needs a bladder neck surgery. A sling was done with augmentation and Mitrofanoff. Similar situation may exist in a thing like cloaca with open bladder neck or an exstrophy patient. Now, coming on to the vexed topic of exstrophy. Now, in my experience, most cases of exstrophy, sooner or later, will benefit from bladder augmentation to maintain reliable continence and stable upper tract. So, reliable continence and stable upper tract, these are the two benefits of an augmented bladder in exstrophy. Now, this I don't say just off the cuff, because earlier in my experience, I used to be quite strongly against augmentation in exstrophy patients aiming at normal voiding, and I did have number of children who were voiding reasonably well and continent, but later as you grow older, these children keep coming back with you as adults. I am not happy with the results. Textbook teaching about exstrophy is very simple. You learn it and vomit it out in the examination. Early neonatal repair, which I am against. Epispadias repair at 1 to 2 years of age. Continence surgery when the bladder has grown to 100 cc, which often doesn't happen at 5 years of age. Then bladder neck plasty, either a young D. Ledbetter with reimplants or a Kelly procedure. And after that, child will be fine, voiding normally, dry between voids to 3-4 hours, and upper tracts remain normal. Unfortunately, this scenario usually doesn't happen. I mean, very often it doesn't happen. So, what is the answer? Now, let us go back to my early cases which have attained continence, reasonable continence. You say there are showcase cases, and I used to show their pictures whenever I talk about exstrophy, see how well they are doing. But things are not good. And I have followed them up for a mean period of 15 years. That shows how old I am. And shows the kidneys are all hydronephrotic to various degrees. And DMSS shows scarring, severe hypertension in some of them, and early CRF in one of them. Remember, 15 years is a short span of time for a normal lifespan. So things are not looking good. That means we have produced an artificial sphincter which the bladder is not reacting well. Time is getting fast. Now, see the bladders. The bladders are able to store urine, but either the bladders become large and flabby, or they are storing much of the urine in the refluxing upper tracts with recurrence of reflux. See the urethra is very narrow, but the storage occurs either in a large flabby bladder or in the upper tracts, which is not satisfactory. If you do a urodynamic study, you see two patterns. One is a very high pressure bladder, rapidly rising pressure, or you keep on filling the bladder and it just doesn't show any reaction. It's a flaccid bladder. Now, this is a typical responses to an outflow obstruction. As you see in a posturethral valve, we are used to classifying them as hypocompliance and then as failed myogenic failure. Same thing is happening here. So again, this is not satisfactory. Now, I have learned the lesson quite quickly and decided that I will not finish treatment with this patient unless they ultimately agree for an augmentation. But I have got some data from Dr. Minu Bajpayee, who has got excellent follow-up data. He has got 152 unaugmented exstrophy patients who have been followed up for more than 5 years. And see, he is terribly disappointed with the upper tracts. See, the serum creatinine already more than 1.4 in 10% of them. Dilating VUR in 42% of them, just I showed you in my cases. Split renal function less than 35, that means already one kidney is going scarring, maybe both kidneys are going scarring, but in 28%, renal cortical scars in 36%, and the very important decreasing GFR. These children are born with normal GFR, decreasing GFR in 65%, less than 79 ml per minute. Remember, exstrophy children are born with two normal kidneys, and if we, by our surgery, spoil the kidneys, we are only to blame. Now, why does this happen? Again, Minu Bajpayee's figures, leak point was more than 40 centimeters of water in 58%. That means the reconstructed sphincter is very strong. But at the same time, the leak point volume is only 50 ml. So they are unable to store much urine. Therefore, his conclusion is augmentation cystoplasty is the solution. I usually advise it around 5 years of age. He says that's too late. We should do it earlier. Now, these are again Minu Bajpayee's figures. See, as he shows after the initial reconstructive surgery without augmentation has been done, the GFR keeps falling till a bladder augmentation is done and GFR somehow stabilizes. And the serum creatinine keeps rising till the augmentation of the reimplants are done, and then it starts falling. So there is an element of reversibility, but why let the GFR fall and why let the serum creatinine rise? So that is why he argues for early augmentation, particularly his favorite gastrocystoplasty. Now, so both Minu Bajpayee and I think that reliable dryness with protected upper tracts is best achievable in the run-of-the-mill patient. I'm not talking about some special cases. In the regular patients of exstrophy that we see, with the combination of augmentation, Mitrofanoff and reimplants along with the YDL bladder neck plasty, and this shows the results of a very bad bladder showing able to store large amounts of urine. And my favorite augmentation for them is what I call a doughnut ileocecal segment with a Mitrofanoff. I'll talk about it a little bit later. It's one of my own inventions. I find it useful, obviously. Now, coming on to the augments, so far I've talked about the indication for augmentations in various childhood diseases, which I think is most important to understand. Now, the primary diagnosis in my total experience of 317 augmented children is the big three: neurogenic maximum 116, exstrophy, another almost equally big chunk, and a much smaller chunk with PUV, and the others like anorectal malformations and all. Now, planning the augmentation is very important. Remember, augmentation is only a part of overall urinary reconstruction. That's very important to understand. Not just augment and just leave the child. Overall urinary reconstruction. So the questions I have in mind is, what tissue should I use for augmentation? We have several choices. Do I need to do any bladder neck surgery in this particular case? How do I plan to do intermittent catheterization after surgery? Because this child has to have intermittent catheterization. So how do I plan it? And what should I do with refluxing ureters? Always discuss the plan with parents, and if possible, show them another patient who's had a similar surgery. Now, tissue for augmentation. There are so many. Remember, bowel is a standard. Of course, there are other methods, but bowel is the standard. And you can use colon as cholecystoplasty. That I've done maximum that because my teacher who taught augmentation, Dr. Saeed Ahmed, that was his favorite operation. And cholecystoplasty is the simplest augment to do. Ileocystoplasty, doughnut, that is the ileocecal augment, and others. Sigmoid, I will not deal too much on the technical aspects because that you can always read up in a book or see some surgeon doing it. Sigmoid cholecystoplasty is the simplest augment. You take a segment of sigmoid colon at its junction of the loop of sigmoid to the bit of the descending, and the vascular pattern you see, and you isolate the bowel, and you open it in the anteromesenteric border, and then you just fold it down on top of the bladder, so it achieves detubularization. The only contraindication is a high anorectal malformation. Ileocystoplasty is again another standard operation. You take a segment of ileum about a foot long, to open it on anteromesenteric border, make it like a U, and then stitch the inner limbs of the U to form a plate, and then you invert the top of the U to reach the anterior wall of the bladder, and that gives twice detubularization, which gives a very effective augmentation, and there is no contraindication to this except short bowel. Ileocecal doughnut augmentation, that is my favorite for exstrophy patients. Now, why exstrophy patients? Ileocecal doughnut augmentation uses an in situ appendix, that is, appendix does not have to be implanted into the bladder to provide anti-reflux mechanism. So the Mitrofanoff has to be anti-reflux. So, and in an exstrophy bladder, often the bladder is a very poor specimen, and already you have to do 2 ureteric reimplants, and also you have to do an appendicular implant into that, and there's not enough space for that. So therefore I devised this operation where the appendix is anti-refluxing by a fundoplication mechanism, where the augment goes around the appendix and provides resistance to leak. It can also be used for valve bladder, can be very useful as a neo bladder, but its contraindication, high anorectal malformation and meningomyelocele, because these two conditions depend on fecal continence on the ileocecal valve. Because the stool becomes liquid, they will become stool incontinent. So therefore, you will be very unwilling to take out the ileocecal valve for your augmentation, and they land up with fecal incontinence. But it's very useful for exstrophy. So diagrammatically, you take the ileocecal segment and make it into a circle with the appendix going first underneath the ileum and then over the ileum, and then detubularize it, make it in one cavity, and you see the whole augment is like a donut around the appendix, and if inflated, that provides the anti-reflux mechanism. And I've done about 100 such patients, and they are very good. They don't leak, and so that, and also if reimplants are required and the bladder is unhealthy, you can reimplant the ureters into the colon segment. So results, I will not deal you more detail because time doesn't allow. You see Here is an exstrophy patient, and the doughnut augment, it shows the circle, and with the whole gap in the center is where the appendix goes through. Similarly, you can see the gap in the center where the appendix goes through. Additional procedures, bilateral ureteric reimplantation either into the bladder or sometimes into the colon segment, and YDL plasty. Ureterocystoplasty, only a few patients, because the indications are the situation that the ureterocystoplasty will be effective are limited. You need really massive ureters to do an effective augmentation with the ureter. If you can, it's very nice. So don't try to do ureterocystoplasty with just moderately dilated ureters. It's a namke vaste augmentation. You really need a very large ureter. So this particular child has a very contracted high pressure bladder, no reflux but massively dilated ureters, and we have used one ureter for augmentation, lay it open, and this child, the follow-up picture is taken about 10 years post follow-up. He is doing well, and the augmentation has maintained its function. Contraindication is the previously operated ureter because the blood supply comes from the lower end. Second important question, do I need to do any bladder neck surgery? Remember that group of conditions. I'll show you 3 pictures with exstrophy, cloaca with open bladder neck, and a neurogenic hopelessly leaking. So these hopelessly leaking bladders, because of gross sphincter incompetence, generally they have normal upper tracts. Mostly are exstrophy patients, some are neurogenic patients. They will need a bladder neck surgery as the competence mechanism, as well as an augmentation to provide adequate storage capacity. So this bladder neck surgeries was done in 128 out of the 317 patients, and 167 had no bladder neck surgery because they were largely high pressure storage kind of bladders. So my favorite one for exstrophy is YDL plasty. If it fails, bladder neck closure, and for neurogenic bladder it is sling, okay, a fascial sling. Now, after having done a bladder neck surgery, or any with or without bladder neck surgery, we have to plan how do I do intermittent catheterization after surgery, because you have to plan it. Without planning, I see so many patients who have had a augmentation because that's something people just do it, but they have not planned intermittent catheterization. So the patient suffers. So the intermittent catheterization can be per urethra or by a Mitrofanoff. If it is going to be per urethra, you have to teach them urethral catheterization before your augmentation is done. But there are certain situations where urethral catheterization may not be possible. For example, obviously a closed bladder neck, or a reconstructed bladder neck as in exstrophy, or reconstructed urethra as in a major epispadias, or rectal malformation, or so on, or cloaca. It may not allow your catheterization. If the urethra is sensate, like a PUV, where if you have to catheterize the child, even once in a PUV, those who have catheterized a PUV patient will know that it is not easy. And if you have to catheterize every 4 hours, the mother will walk out of the marriage. So a sensate urethra is also a problem for urethral catheterization. And then again, some situations the urethra may be catheterizable with difficulty. For example, when there is the urethral cul-de-sac, for example, in anorectal malformation, the little bit of pouch that remains, or in a UG sinus, you can't even see the urethral orifice, or a cloaca. And of course, cloaca itself is a major condition where urethral CIC may not be possible. So in these patients, if you do an augmentation, you should provide a Mitrofanoff channel for easy catheterization. So that's very important. Now, I have been very pro Mitrofanoff, so because I want the patient not to suffer. And so it has been done in 292 out of 317 patients. So all exstrophy epispadias cases I think is essential. All PUV cases I think is kind to do rather than make the mothers and child suffer. And on neurogenic bladder, it may be optional or maybe kind in non-neurogenic bladder. There's a special kind of neurogenic bladder which no demonstrable neurological cause is found, but they have a sensate urethra. So therefore, it is better to do a Mitrofanoff when you're dealing with neurogenic bladder. So this is a child who was very uncooperative for urethral catheterization, but very, very cooperative for Mitrofanoff catheterization. Now, having said that, what sort of Mitrofanoff? The favorite and most effective is the appendicular Mitrofanoff, 250 of them. Ureteric Mitrofanoff is okay, but it is more troublesome than appendicular Mitrofanoff. It is more sensate and the catheter tends to kink and obstruct in ureteric Mitrofanoff or the ureter may reflux. So sometimes I've done both. If I had a main Mitrofanoff was the appendicular, and if I had a spare ureter stump, I just leave it as a Mitrofanoff. So there have been both, and sometimes it has saved the patient's catheter, because sometimes the appendicular also can give trouble. Monty channel, 7 patients, but Monty channel tend to be a little tortuous with time. Now, when everything is nothing is available, I've done a gastric tube, which also was a very nice Mitrofanoff based on the gastropulpic vessel. Instead of doing a large patch like a gastrocystoplasty where Minu Bajpayee does, I take a small strip of stomach wall of the greater curvature and make it into a tube, and that it works very nicely, though sometimes they can get a bit of skin ulceration. Other thing, colonic tube, bladder tube are episodic. Now remember, Mitrofanoff is what the patient is going to see, the relatives are going to see, and cosmesis is important. I try to make it absolutely cosmetic, and if you have a Mitrofanoff like the first patient with the thing prolapsing out, we can't sell the operation. Whereas this is a child who has had a Mitrofanoff about 15 years ago. Now he's an adult. He came for a follow-up recently, and you can't make out. Of course, he's put on a lot of weight, but you can't make out, and it is very cosmetic. So majority of our Mitrofanoffs are cosmetic like this. Next, very, very important question, what should I do with refluxing ureters? So many of these patients would have major reflux. Now, high pressure reflux is very dangerous for the kidneys, and bladder augmentation reduces bladder pressures drastically. So one may think that why not just do an augmentation, the reflux will become less dangerous. That is correct. Reflux will become less dangerous, but is it enough? So the important questions are, does reflux disappear consistently after an augmentation? And secondly, if it does persist, is it harmful? Now, so in the earlier days, I used to, if the reflux is there, and if I'm augmenting, I sometimes would leave the reflux alone thinking it is going to subside after augmentation. Now, these are 2 exstrophy patients where a reflux has persisted because we have not tackled it. In this side also it has persisted. They have had doughnut augmentation, as you can see. And because of the reflux, there is a minor scarring in this kidney, and there has been some episodes of UTI. And this side also, this kidney is not as good. So, though it's not as bad as untreated high pressure reflux, persistent reflux after augmentation may also be harmful. And I purposely put exstrophy cases because they are born with normal kidneys. You cannot say this cortical defects are due to dysplasia. Now, second question, does reflux persist after augmentation if no anti-reflux surgery is done? We have data on 42 such ureters who have demonstrated reflux before surgery, and we had a post-operative MCU to show the reflux persisted. So, or reflux is there or not there. So, of course, we have stopped at 42 because subsequently I have always done an anti-reflux surgery. So, neurogenic bladder, when we have not done a reimplant, 29% of refluxing ureters still refluxed, which is better than, of course, 29%, not a very high figure, but for those patients it's important. In the few valve patients, all resolved, but subsequently after this slide was made, I have had another child with valve, it has not resolved. But in exstrophy patients, 60%, more than half, still reflux if you have not done an anti-reflux surgery. So therefore, come to the conclusion that augmentation is helpful to resolve reflux but not 100%, and persistent reflux, though not as damage as before, can still do some damage. So therefore, if it is better to correct reflux at the time of augmentation. I have followed that policy since I've had these problems. Sometimes this anti-reflux surgery is the most difficult part of the operation because these bladders are horrible. So I have devised methods to obtain a safe reimplantation in such bladders. Time does not allow me to go into that. If the bladder is very bad, you can implant it into the bowel, but it is always better to make an effort at doing anti-reflux surgery at the same time as augmentation. Complications. Immediate complication, the most frequent, is adhesive intestinal obstruction, and 22 out of 283 patients Now this analysis was done when there was 283 patients. Subsequent, we have to still analyze the remaining patients. Wound dehiscence was in 4 patients, and after augmentation, wound dehiscence is a very horrendous complication because the entire augment comes out of the wound. Anastomotic leak in 4 patients. Augment necrosis, fortunately, we had only 1 patient. It was not done by me but one of my colleagues, and we recognized it after a week after surgery and revised and put another augment in place, and it's doing well. Ureteral necrosis can happen due to ischemic thing, and that we have to revise it. Late complications, 283 minus 57 because 57 are still early patients, are urinary leak with a perforated augment in 5 patients, which can be a dangerous complication. Mitrofanoff stenosis in 16 patients. Obstructed reimplant in 2 patients. That's we have to be very careful of the reimplant. Bladder calculi, I will talk about a little later. Metabolic acidosis, everybody talks about, and we put all our patients on prophylactic soda bicarb tablets. I don't know whether it does any good, but they are all come for follow-up because they have to get the soda bicarb tablets. So it doesn't do any harm. So in my experience, acidosis is very rare and it's only seen in advanced CRF patients. And we don't know if it is because of CRF or due to the combination of augmentation and CRF. And Dr. Minu Bajpayee will tell that gastrocystoplasty is very good for such patients. But I don't have any experience in gastrocystoplasty, therefore I have not spoken about it. But we do electrolytes for every patient who comes for follow-up every time, and I've never seen any major metabolic complication provided they're not in CRF. Bladder calculi is an important complication, and we have had it in 16 out of 283 patients who have been followed up for a good length of time, many of them more than 10 years, some of them 5 years. I think mean follow-up in this study was 5 years. But there are some interesting facts about the 16 patients who have had calculi. In fact, that's a very low number if you compare world statistics, because I'll tell you why. Now, 12 out of the 16 were exstrophy patients, 4 of the 16 had pre-augment calculi, 12 of the 16 had bladder neck procedures, 13 of the 16 were catheterizing by a Mitrofanoff only, and the type of augment didn't seem to matter. So it all shows that stone formers, particularly exstrophy patients, are the ones that are to watch out for. Then those who catheterize only by Mitrofanoff, because the urethra is not catheterizable, they tend to collect mucus at the bottom which forms a stone. So calculi is particularly prone to form in these exstrophy patients. So you have to be especially careful with these patients with post-op care. Now, malignancy, everybody talks about malignancy. I haven't had any malignancy in our patients. Maybe I'm not old enough. But I've taken this statement from a very nice book written by Snodgrass, Pediatric Urology, Evidence-Based Optimal Patient Management. And that says a prospective assessment at median follow-up of 27 years after enterocystoplasty found smoking and immunosuppression after renal transplantation, but not augmentation per se, associated with the increased malignancy risk. So I am very encouraged by that statement, and I leave it with you. But that is not true for ureterosigmoidostomy. Ureterosigmoidostomy has a high chance of malignancy, and the very few ureterosigmoidostomy which I have seen, one of them had a malignancy. So she is doing well after surgery, but it's a real risk, but not so much in augmentation. Mortality, yes, 15 out of 317. The immediate post-op was only 2 because they were sick patients in renal failure, and they also had wound dehiscence and sepsis, and so they died post-operatively in the immediate post-op period. 2 probably died of intraperitoneal urinary leak at home because they reported the suddenly the child abdomen became distended and the urine stopped coming, and they died before they could do anything. And progressive renal failure is the main cause of death because some of them are already in renal failure, and I'll talk about renal failure a little later. There was one suicidal death in a patient who was otherwise well, and as an adult, we don't know what is the cause. At 10 years post-augmentation, he took some sleeping tablets. Now, how does augmentation benefit the patient? Now, this analysis has been done in 178 patients, not because we have something to hide in the remaining patients, but to analyze this large number of patients, we need our registrar trainees who are willing to sit and analyze all these complicated charts. Even one chart will look scary, and they have to analyze so many charts and x-rays while the bosses keep on operating. So it is difficult to get such registrars, and we have been able to do it occasionally. And so the detailed the follow-up is in this particular slide is on 178 patients. What the augment does is a very high pressure storing bladder or potentially high pressure storing bladder converts to a bladder which is very flaccid. Relief for incontinence was seen in 173 out of 178 patients, and the patients and their families very happy. Resolution of hydroureteronephrosis was seen in 112 118 patients, and this makes the doctors very happy. Resolution of VUR was seen in 121 of 153 refluxing units. That is because we did not reimplant in some of them, as I told you before. Now, resolution of renal failure is a very vexed question and a gray area, because augmentation works best as a prophylactic measure. Already when you see the kidneys are getting hydronephrotic and the repeated UTI is a time to intervene. Once the creatinine has gone up, especially beyond 2, then the augmentation may halt it for some time. In some cases it reverses to some extent, but in many cases, particularly in posturethral valve, it just delays the onset of end-stage renal failure, maybe by even 10 years, 15 years, but it cannot halt it completely. So therefore, resolution of renal failure data will depend upon how many years after augmentation you have taken the results, especially in cases who have exceeded serum creatinine of 2 at the time of augmentation. So in these patients, augmentation is a delaying maneuver and a preparatory to transplantation. Otherwise, it cannot give a long-term, lifelong solution. Now, this slide says it all about this child came to at the age of 12 with bilateral hydroureteronephrosis, is a anorectal malformation with neurogenic bladder, sacralogenesis, as well as the urethral stricture, and he was in sepsis, he was incontinent, and serum creatinine is 1.8, a massive reflux on one side, both sides you can see the hydroureters, and one side kidney was enormous, that's the refluxing side. And so we resuscitated him with a suprapubic drainage because we couldn't catheterize him per urethra, and we augmented him. And you see, the bladder was so bad I didn't dare to reimplant. I just let the augment be, and then I didn't even reimplant him. And his kidneys look very good. And in fact, I thought they're the same. The ultrasonologist made a mistake, but both kidneys are like that, which has been resolved very well. He's a doctor now. He has done medicine, and he is working in a government hospital, and his serum creatinine after 12 years or in fact more 15 years follow-up remains at 1 milligram per deciliter. So he is one on all counts, except that he has to do intermittent catheterization, and he is wanting marriage, and so he's wanting I have to get a wife for him who is willing to help him doing intermittent catheterization. Now remember, as I told you, the stone forming and the mucus, you have to teach them bladder wash. I insist that every day they have to give bladder wash with just nothing but tap water and a pump, hand pump. They just push it and let the thing out every 5 or 6 times. As I said, so patients ask, do you have to do it every day? I said, don't you brush your teeth every day? Yeah, you do brush your teeth every day, so why not clean your bladder? So purposely I have taken this picture like that, the child brushing his teeth and the mother giving the bladder washouts. And remember, it is the life of catheters. You can't escape it. So this is a funny picture we have taken. This picture is with my friend Sampath Kal and myself about 10 years ago. And this is one of our patients who still comes for follow-up. And we make catheterization easy, giving them bags and catheters. They don't have to buy each new catheter very often. And the cloth bag keeps it dry and clean. And I don't know if Sampath is watching my talk, but probably he'll be in church or something. So hello Sampath, and thanks for helping me with all these cases. And before I end, Pave told me to wear a blue shirt because that will project better. And I suddenly find this shirt I'm wearing today, a blue shirt, is probably the same shirt which I'm wearing in this picture. It's just a coincidence. Thank you.
You need to read it
Yeah.
out. You
No,
need
no.
to read it out.
Tell me.
Let's see. Shall I read it out?
From say, when do we decide to leave a distal stump for night drainage after antiversion? Yeah, distal stump for night drainage after antiversion. If it is available, you can use it. No problem. It's not part of the augmentation, but why waste it? And now, only question is that stump refluxing or non-refluxing? So, with refluxing, it will be a bother for the patient because that will keep on leaking urine. But if non-refluxing can be used. But a refluxing stump with an augmentation is also very useful. I published a paper in Pediatrics International about many years ago where a refluxing stump can be used as a catheterization channel which does not leak very much provided you've done an augmentation. But if you've not done an augmentation, refluxing stump is useful but may leak. But you may you obviously you can't do a regular reimplant because you will be interfering with the blood supply at both ends. But you can do an extravesical procedure to make it anti-refluxing. I don't know if that answers your question. But anywhere a stump is available, you can do it.
Raj Kiran from Bangalore, please clarify if the ureteric reimplant needs to be done onto the bladder template only or onto the ileal or colonic patch.
Yeah, so this is a important question. Now, if the bladder is reasonably okay, I would prefer to do it in the bladder plate because that gives a nice detrusor backing, and you may not need a very long augmentation. If the bladder is heavily trabeculated, I don't make a submucosal tunnel. I just incise the bladder mucosa, reflect it on both sides, and lay the ureter on the bladder bed, and the mucosa will grow over it. So that is a very safe technique. Now, if the bladder is hopeless, very inflamed or very fibrotic, then I would implant it into the not into the ileal segment but in the colon segment, and I have perfected a technique for implanting into the colon segment by deserosalizing a portion of the colonic wall within the augment. Time doesn't allow me to give the details, but maybe at some later point I'll talk on difficult reimplants and the methods to tackle it. So you can put it in the colon segment, yes. But ileum is not a very good detrusor backing, muscle backing for it.
Raj Kiran, do we need to repeat UDS after a bladder augmentation surgery? If so, what time frame are we looking at? Please clarify.
Yeah, I think it's nice to do urodynamic study after augmentation also, because particularly to know whether the augment is adequate, and sometimes the augment segment, particularly the colon, can generate a lot of pressure, and as a particularly later phases of filling. So there are some patients who will show contractions of the augment segment, particularly colon, and that can be treated with anticholinergics. So I think we should do, to be on the safe side. Generally, we do urodynamics on most of our augmented patients, maybe after 6 months to after surgery.
Vinay from Narayana, what should be the minimum age of a child to undergo augment?
There is no such thing. The child has to be augmented when he needs it. Now, you might laugh that I have even augmented newborns, very rare, but I have, because of the exstrophy. Some of the exstrophy plates are so bad that you can't just invert them to provide a closure, and you already mobilized the bladder for exstrophy closure, and you are not able to invert it to close the bladder. In that situation, you have to, only way is to put an augment segment on around the bladder. So bladder will form the back wall carrying the ureters. Obviously, you can't reimplant in this situation, and the augment will provide all the other walls. So that is a situation you may have to augment in the newborn stage. But otherwise, most of the augments have been done in maybe 5, 6, 7 years of age. But then there is no rule that if the kidneys are deteriorating before that, you may have to augment in a neurogenic bladder or in a valve bladder. But in infancy, generally, we opt for a diversion kind of thing and see if the bladder recovers. If it has a PUV, the bladder will recover, as I show in many of the patients, as I showed in my some of the examples. Similarly, in neurogenic bladder, the situation can be tided over with a diversion, like a vesicostomy, and then later you reassess the bladder what has happened. Now, unfortunately, valve bladders usually have a tendency to recover, but neurogenic bladders don't have the tendency to recover because there's something gone wrong with their neurological supply. So therefore, they'll probably ultimately need augmentation. Exstrophy bladders, of course, they will need augmentation.
How safe is CIC in children who have major reflux?
Yeah, that's a very important question again. So if major reflux is there, in a case of neurogenic bladder, CIC is often advised in the textbooks, and we used to do it. But in my experience, um, it often causes infection, and one attack of infection in a high pressure reflux can cause a lot of kidney damage. So therefore, I would rather tide over the crisis by doing a diversion if they're not willing for an augmentation, and then plan augmentation along with some sort of anti-reflux surgery, and then put on CIC rather than doing CIC as a beginning in a major dilating reflux in neurogenic bladder. That's my opinion. I know a lot of people would persist with CIC, but I think we lose more nephrons that way. And I have tried that, and the child has ultimately needed a kidney transplantation with normal kidneys to start with.
Role of redo bladder neck procedure, where previous augment with YDL bladder neck procedure failed to achieve dryness, though capacity is good.
Yeah, that's not an uncommon situation. About 25% of YDLs may fail in spite of an augmentation, and then you need to go for a bladder neck closure. Now, the advantage of doing it in two steps like this is that by that time you already know that your Mitrofanoff is quite stable, and quite they are using the Mitrofanoff, and it is easily catheterizable, and it's quite safe to divide the bladder neck at that stage. But sometimes bladder neck, so many of my bladder neck divisions are like that. But some cases we have primarily gone for bladder neck closure if I think the bladder is too unhealthy. So the bladder has to be reasonably healthy to do a YDL, because after all, using the bladder wall itself to provide that channel. If the bladder wall itself is very small or very fibrotic, you can't do it, and you have to do bladder neck closure. Sometimes neglected exstrophies will come after 5-6 years, and it will be a tiny little ulcer-like thing. The bladder plate will look like a small ulcer. So obviously you can't do YDL in that situation. But having said that, my YDLs have been improving and improving with time, because originally I used to do YDL to provide a channel for normal voiding, which is a wide YDL. It doesn't work. And you have to do the YDL reasonably narrow and long, particularly. It has to be long, then only it works. So recently my YDLs have been succeeding quite well.
Kanishka, do you believe all kidneys are normal at birth in neurogenic bladder as in Exstrophy? Thought several of them were abnormal, had already gone bad prenatally.
Funnily, it may be so, but in my understanding, neurogenic bladder does not cause kidney damage antenatally. I have asked several people why, nobody is able to answer that. Whereas PUV causes a lot of kidney damage antenatally, in fact maximum damage antenatally, but neurogenic bladders do not cause kidney damage antenatally, but can cause rapid damage in postnatal. Sometimes it takes years, sometimes a few months. So something happens after birth where the kidney damage starts. I don't know what you think, but that's what I feel. I know that.
Dr. Tripathi, doctor, please share your experience on residual valve in PUV.
Residual valve is, I don't get much residual valves in my own patients because I fulgurate quite thoroughly, but only in 12 o'clock position. So it is safe because I'm fulgurating only in 12 o'clock position and not in 3 places. So therefore, you can be quite happy about cutting up the entire membrane. So I am not very worried about residual valves. But of course, we see a lot of residual valves in patients who have been fulgurated elsewhere, and you have to check that before thinking of other things. But I think it's a overdiagnosis. Anybody who has a problem after PUV fulguration, The first diagnosis is residual valve. That is only one of the diagnoses, and you rule it out and then proceed.
Dr. Gupta, closing the UB neck is a challenge. What is your choice to do it?
Yeah, closing the bladder neck is a challenge, and there are some technique which I feel is important is when you divide the bladder neck, you lift up the posterior wall of the bladder. You'd be careful of the ureteric entries as much as possible. So the posterior lip of the bladder faces anteriorly. It faces away from the remaining urethra. So the posterior bladder wall or bladder neck wall is dissected behind it so that it faces forward. And then the augment comes and meets it. So it is not the augment is sitting at the top and you divided the bladder neck below. The divided bladder neck itself is the place where the augment will come and attach itself. That's one issue. So there is no tension at that place. And secondly, if a rectus muscle is available, I mobilize the lower half of the rectus, keeping the attachment at the pubic bone and the blood supply from the inferior epigastric artery, and divide it somewhere higher up, and then swing it down to cover that entire the divided bladder neck. So that has given me 100% results. I mean, I haven't had anybody who has leaked through that repair. It was published actually in again Pediatric International.
Dr. Jindal, how long to wait before deciding for augmentation after diversion in a neurogenic or PUV bladder?
Well, if the child is stable, it depends entirely on what the family wants. As long as the diversion is there, the child will be okay. But as soon as you close the diversion without re-evaluating the bladder, child will go bad. So therefore, you have to probably before going to school and things like that. There is no, it's not a medical reason, it's only a social reason.
Questions? Any questions?
No questions.
Want to close it?
Yeah, thank you very much, and please enjoy the rest of the Sunday afternoon. Okay, no?